Hello everyone. In this presentation, we will talk about neonatal shock. We will be talking about all the basic things, clinical pathological definition of the neonatal shock, how we classify neonatal shock, what are the various causes of the shock, how we diagnose, and while diagnosing and managing these babies, how we monitor these infants. If we talk about definition, clinical pathological definition of the shock, it is a clinical syndrome of acute circulatory dysfunction which results in insufficient delivery of oxygen and vital nutrients to the tissue, which is relatively lesser to their actual metabolic demand. And also the metabolic end products, byproducts, are not being flushed out from the tissues and those cells. And therefore it leads to the cell death and organ dysfunction. It is very difficult to know about the true incidence of shock in newborn infants from the published data also, but one thing is well established: the incidence is higher in the preterm babies as compared to the term babies. We will discuss about the causes of shock in this presentation, but to know about the most common causes of neonatal shock in Indian scenarios are sepsis, birth asphyxia, and the congenital cardiac diseases. The mortality is pretty high in preterm babies, till like it is more than around 70%. The mortality is also in high if the etiology is sepsis and congenital cardiac diseases. Earlier we detect shock and manage, we can prevent the mortality, and outcome will be much better. When we classify shock, simply we can divide it in hypovolemic shock, where your preload, that the intravascular volume, is being lost. So the most common reason is antepartum hemorrhage. Then we classify it as a cardiogenic shock, means the pump failure, the heart is failed to pump the adequate amount of volume of blood to the tissues. The most common cause is hypoxia, and the most common etiology may be perinatal asphyxia. Distributed shocks are those in which the intravascular volume is being distributed because of the dilatation of the vessels, or intravascular volume goes to the extravascular volume. The most common reasons in pediatric and adult is the anaphylactic shock, but in newborns it is not very common. So that's why it becomes mostly it is in combination of mixed shock. It's a part of mixed shock, like in sepsis. So in this, as you can see in the figure below where the sepsis has been written, the myocardium is affected, therefore the pump is affected because of the inflammatory intermediates, the in because of sepsis, and the vasculature is being dilated because the autoregulation is lost. So you have a dilatation of vessels, because of that there is a stasis of blood, so there is decrease in the preload, and your pump has failed, so it has become a mixed shock. So there is a part of distribution failure, and then there is a part of myocardial failure. Then in normal situation where the hemodynamics is normal, the blood pressures are normal, you as you can see in the figure up on your screen, your afterload and preload is being maintained normally. In hypovolemia, what happens? Your intravascular volume is lost, as in some bleed or dehydration. So you will have less volume, even though your heart is being pumping properly, but even then it will be a failed pumping of the adequate amount of blood volume to the tissues because of less intravascular volume. If there is a pump failure, as in cardiogenic shock, even though your intravascular volumes are adequate, but heart is not pumping properly, so your tissues or cells will receive less volume of blood because of the decreased output from the heart. So when we talk about the pathophysiology, the normal determinants which maintain the hemodynamics normal. Why we call it normotensive? Because most of the times when we talk about shock, we correlate, like we always try to assess this infants or patient by blood pressures. So that's why your blood pressures are normal, means you are normotensive, your hemodynamics is normal. But now we know it is not the blood pressure that is the sole determinant of your shock. The main two things which maintains your normal hemodynamics is normal cellular metabolism and your normal cardiac outputs. So even your blood pressure is a product of cardiac output and SVR, that is systemic vascular resistance. So your tonicity of the vessels is also an important component to maintain the normal pressures. So when we talk about cellular metabolism, how it is being maintained, it is being maintained by two components. Cardiac output, we will talk about this in the next slide. And then the oxygen content of the blood the cells are getting through the proper pumping of the heart, cardiac output. Okay, so the blood component, oxygen component of the blood is being determined by two things. One is the oxygen saturation in the blood. For that, it has been dependent on the lungs because the gas exchange takes place. So if you have pulmonary issues, you will have issues with the oxygen saturation of the blood. And if you have some cardiac disease where there is a shunting mixture of oxygenated and deoxygenated blood, even then you will have issues with the oxygen component, oxygen content in the blood. And if you have a lesser hemoglobin, so the oxygen carrying capacity of the blood will decrease. So therefore, ultimately you have a lesser oxygen content in the blood. So that is how it affects. And if cardiac output we talk about, because the blood pressure is also a product of SVR and cardiac output. And cardiac output further is a product of stroke volume and heart rate. Stroke volume is the amount of the volume of blood that is being pumped out of your heart or left ventricle in one contraction. And heart rate, as we all know, it is a number of times the heart beats in 1 minute. So see, the stroke volume is very well dependent on few components of like afterload we talked about, preload, contractility of the heart. In newborns, especially in the premature babies, your myocardium is not very well developed. Okay, so when your patient gets a shock, the early phase of shock, the body tries to compensate. Then both of these stroke volume, the myocardium also try to compensate, and then your heart rate. But in newborns, especially in the preterms, the myocardium is not very well developed, is very weak, does not play much role in the compensation. So your heart rate is one of the main component in the newborns, which plays a major role in compensation. So newborns, they become tachycardic. So that's why the earlier shock is being detected or can be detected represented by higher heart rate, tachycardia. And as you can see, all these components are interdependent on each other, and each system is interdependent on each other. Because of the oxygen content, it is dependent on the lungs also. So the heart functioning indirectly is also been affected by the lung functioning. So all systems are interdependent, and all different pathophysiological components are interdependent to each other. If we talk about the causes, the first and foremost thing, especially in the preterm babies, one is the immature myocardium. And then the next thing can be your, because the autoregulation of the vessels is not very well developed, so immature peripheral vascular resistance, and hence your vessels they dilate, and hence your P load becomes less. Especially even though the intravascular volume is less, because of dilatation the preload becomes less. Ductus artery, PDA, especially in the preterm babies, it is very important because it takes away your systemic blood to the pulmonary side, and hence you have systemic decrease in the systemic circulation. So you have pulmonary overcirculation and decrease systemic circulation because shunting of the blood through the PDA. Sepsis itself can cause disruption in the myocardial functions and vascular autoregulation. Hypoxia because of meconium or perinatal asphyxia will lead to myocardium dysfunction and cause PPHN, which further leads to dysfunction of the ventricles. Myocardial dysfunction may be because of metabolic cause or septic cause. Genetic means if you have inborn errors of metabolism, the acidosis it created causes myocardial dysfunction. High pressures in the ventilation will lead to raised intrathoracic pressures and hence indirectly causes decrease in myocardial functioning and decrease in the preload. Hypovolemia may be because of IVH or antepartum hemorrhage. And then these premature babies, they have catecholamine depletion state, their adenary insufficiency, and hence it can lead to the shock. In this table, you can see the various etiologies, how they present clinically, And what is the major pathophysiological component which is causing the shock in these patients? Like for example, in perinatal asphyxia, most of these patients they will present with weak pulses and prolonged capillary refill time. That is a common presentation for most of the babies presenting in shock. In this, you may have baby present with seizures. The predominant pathophysiological component which causes shock is myocardial dysfunction. Transition circulation in EL, especially babies less than 28 weeks. In this, you will have decreased urine output along with other clinical presentations. The main pathophysiological component causing shock is LV dysfunction because of LV is being suddenly exposed to higher afterload. PDA, shunt. We have already discussed the main physiological component causes shock is because of decreased systemic flow, because of ductal steal. They present with all the clinical features of shock, plus they will have bounding pulses and they will have increased ventilatory requirements if their baby is already on ventilator, or increased need of oxygen. If baby presented with sepsis and shock, then you will in history you will get the lethargies, activity will be decreased, urine output will be less, and we know it is a kind of mixed shock. So myocardial dysfunction and vasomotor dysregulation is the main cause of shock. In hypovolemia, if it is because of the excessive blood loss, the infants will be the babies will be pale, and the main issue is decreased preload. In if the baby presents to you with congenital cardiac issues, duct dependent issues, there is very typical history that they present the babies is well in the first 2 to 3 days of life, then suddenly they crash, because that is the time when the pulmonary pressures they decrease and the duct starts to close, and as soon as the duct close, the babies they become present with the shock. So on examination, when you see, there will be a difference between upper and lower limb pulses, and there will be difference in upper limb and lower limb blood pressures. And the main cause is there is a physical obstruction to the systemic outflow of the blood from the left side. If you have the baby with high pulmonary pressures, the main component that causes shock is myocardial dysfunction. Even though high pressures they will lead to RV dysfunction, but indirectly both the ventricles are interdependent. So RV dysfunction will lead to LV dysfunction. They will present with respiratory distress and increased ventilatory requirements. And if they have raised intrathoracic pressures because of pneumothorax, or they are on ventilator with high inspiratory pressures, again they will present with this clinical presentation of shock. But if you do an X-ray, you will see hyperinflated X-ray chest. And the main issue is because of the high intrathoracic pressure, they will have a preload decrease, less blood volume is going into the heart, and hence ultimately it will lead to myocardial dysfunction. So when you are approaching to manage these shock babies, the first and foremost thing is you have to recognize that they are in shock. The next step is then you have to determine the severity of the shock. While doing this, you have to determine and define the etiology, because if you know the etiology, only then you can evaluate and plan a treatment for these specifically. Therefore, the proper and quick clinical assessment, along with the assessment, doing that, recording the vitals, and planning the investigations is very important in while managing the shock. And echo is become an important part nowadays for management of the shock. So for diagnosis, what we all need, history we cannot leave. We have need to have a proper and quick elaborate history appropriate to the case. We have to record the vitals which are appropriate to the condition, examine the infants well, and then plan the investigation. So when it comes to the history in the newborns, it starts with the antenatal period, antenatal history. You need to know, like if there was a placenta previa and baby has come to you in shock with pale, so that clearly shows that there was a antepartum hemorrhage. Or whether there was some congenital anomaly which was been picked up in antenatal ultrasounds. So you should have a proper and dependable antenatal history. Then you should ask for perinatal events, if whether there was some asphyxia which was going on in the perinatal time when the baby was born, and now the baby has presented to with the seizures and the shock. Feeding history, why it is important? Because that is one of the major factors that tells you whether the baby was active and properly feeding, say 8 to 10 times in a day. And the cry activity, again, it's a normal activity which will tells you that the baby is being hemodynamically stable or not. Urine output, we ask like whether the baby passes 6 to 7 times in 24 hours or not. And abnormal movements, again, for like in asphyxia, the babies may present only with seizures and then they can present with shock. First is the heart rate. Heart rate you can get from the putting on the like when we put on the monitors, like now we have the monitors everywhere. SpO2 probe, and you put it gives the heart rate, or you can do it by palpating the pulses or by stethoscope auscultation. Whenever you put a probe for recording SpO2 oxygenation of this baby, always make a habit to do it preductal, that is in the right hand, and then postductal, that is any of the lower limbs. So that will give you an idea also whether it is cardiac or not. Then the capillary refill time, CFT, it is preferably to be done on the sternum with your thumb or pressing for 3 seconds, and then you see how much time it refills. Normal is 3 seconds or less. If it is more than 4 seconds, it is being prolonged. Touch the extremities with the back of your hand and touch the center core, the trunk, with the back of hand. If the extremities are cold, it can be early sign of shock. Record the temperature. The peripheral, you can do it in the axilla, and the core temperature you can record the per rectally. If there is a difference of more than 1 degree Celsius, that is again pointing towards the early shock. If you are, then the blood pressure we can do non-invasive blood pressure, but we have to be very careful regarding the size of the cuff, because whatever cuff you are using, it should cover 2/3 of that limb. Okay, if you are doing in the arm, the upper arm, if you are doing the legs, the upper part of the legs. Make a habit to do blood pressure in all the 4 limbs. While palpating the pulses, the easier ones to palpate in the babies, one is the femoral for the lower limbs, and the upper limb, radial sometimes in preterms is difficult to palpate. Okay, then we generally do the brachial upper limb in the upper arm. So brachial and femoral, at least we should palpate upper limb and lower limb pulses. And this perfusion index is nowadays, you can see in your multipara monitors when you put on the SpO2 probe, there is pulsatility, like that goes like pulse. So normal is anything more than 0.8. So, but one value is not important. In serial, it will give you the information whether the baby's perfusions are improving or they are deteriorating. This is the normogram of the blood pressure, mean blood pressure. On in excesses, you will see the age in hours. And this is for the different gestational age, like 23 to 26 weeks, 27 to 32 weeks, 33 to 36 weeks, and 37 to 46 weeks. So if you want to know the 50th percentile or percentile of blood pressure, mean blood pressure of baby or 33 to 36 weeks, 36 hours of life, you can evaluate in this chart. Similarly, you have the charts for systolic blood pressures and diastolic blood pressures. So you should make a habit of checking the blood pressure and then plotting it on the normograms, both for systolic, diastolic, and mean, all three separate. Previously, we used to take, for the numbers as mean blood pressure is equivalent to gestational age for the baby, but that is not the right way of doing it. Now we have the normograms. We have to plot these normograms as per the age and gestation, and we should look for diastolic, systolic, and mean blood pressures, all the three components. In this table, you will see that there are few clinical assessment, clinical observation pointers, how they will look in a normal infant and in an infant presents with the shock. Skin color, normally the babies are pink, but in shock the babies are maybe pale or they be mottled. If you record the temperature, the normal core temperature in a normal baby is 36.5 to 37.5 degrees Celsius. These babies may be cold, or there will be a difference of core to peripheral temperature of more than 1 degree Celsius. If we palpate the pulses, they are well felt and they are equal in upper and lower limb in normal babies, but they are feeble. Or if there is a duct dependent lesion, then there will be a difference in upper limb and lower limb pulses. Capillary refill time is in normal baby is less than equal to 3 seconds. Babies presenting with any kind of shock, It may be prolonged more than 4 seconds. Normal heart rate is around 110 to 160 in the normal babies. But as we discussed, because they may compensate, so the babies they present with tachycardia. If the babies are in shock and they present to with bradycardia, it means that compensation phase is being over. So they are very sick. The mean blood pressures, as we discussed, if it is non-invasive also, it has to be invasive or non-invasive, it has to be seen on the normograms. If it is less than third percentile for the gestation and the age of the baby in the normogram, then it is most likely, then the baby is in shock. Urine output, normal output is 6 to 7 times in 24 hours or 1 to 3 ml per kg per hour, but it will be low in the babies who are presenting in shock. The babies who are normal, like cry activity, their sucking and swallowing will be normal. But the babies who are in shock because of any etiology, they will be lethargic. The investigations which can be done quickly and which are very important to rule out the common causes should be done first. And then that's why we divide it in first line investigation, second line investigation, third line investigation. Initially, when the baby comes to you in this condition, quickly you have to check for the sugars. Rule out sepsis by doing CBC-CRP. Serum calcium electrolytes are to be done immediately. And then we have to act if any of these are abnormal. Second liner is we need to know if it's sepsis, we need to know the bugs, we have to start the antibiotics and the cultures, take the blood gases, do the serum lactate and X-ray chest. And the third liner is sometimes, very rarely, it may be the arrhythmias which are there in the newborns, which is more common in bigger babies or in adult. Get the ECG, heart racing, get the head ultrasounds to rule out IVH, need to do in functional echo or echo to rule out any cardiac anomaly or whether to see how the heart is pumping and functioning. Serum ammonias and ketones to rule out inborn errors of metabolism, and then bleeding PT, APTT, INR just to rule out whether there is a any issues with the bleeding. Once you have assessed the baby is in shock, okay, and then clinically in vitals you have already been recorded. Other thing is the next step will be you have to stabilize the babies. So first thing we have to maintain temperature for these babies. It is very important. Maintain ABC, airway, breathing, and get the vascular access. Because if we need to treat, we need to give antibiotics, we need to give volume, you need to have a vascular access. First thing is we can give if any of the etiology, we can give at least one bolus of normal saline 10 ml per kg. Repeat the bolus definitely if it is hypovolemia. But if the babies are preterm, LBW or ELBWs, then we have to be cautious to give the repeat bolus. And in ELBW babies, if you are giving bolus, don't give it very fast. Give it slow over 10 to 15 minutes. Otherwise, it may lead to IVH. If there is hypoglycemia, hypocalcemia, correct that. While assessment, if you have a doubt that it may be a drug dependent cardiac anomaly, have a low threshold to start with the prostaglandins. Even though if you don't have an echo done, even then you can start with the prostaglandins. If the babies have not responded with the bolus, then you can go ahead and start with the inotropes. It has to be very specific as per the etiology. Like suppose if you have a sepsis, the first inotrope we will start will be dopamine. The doses is ranging between 5 to 15 micrograms per kg per minute. And if the baby has gone into shock because of hypoxia and asphyxia, the first choice will be dobutamine. But the ground rule is if you have reached 15 mics per kg per minute of any of these inotrope, don't go on increasing the dose. Consider the other inotrope. And then by that time, always tend to ask for echo. In ELBW babies, because they are catecholamine depleted, give early steroid. If you are adding on the other inotropes, start with the steroids. There is quite a big evidence nowadays, good evidence now to start early epinephrine. The dose is 0.05 to 1 mics per kg per minute. In pediatric and adult, they use quite a lot of NORAD and vasopressin, but that is not sufficient for the newborns. But vasopressin is quite being used in shock, especially in babies with hypoxia and PPHN. Till that time, if the baby has not responded, if echo has not been done, try to get the echo done and rule out the congenital anomalies or any other cause, pericardial effusion. Get an X-ray chest done, a cold light source or anything, or ultrasound to rule out the pneumothorax or high intrathoracic pressures if the baby is not responding to any of these. So the take home key messages from this presentation is, in etiology of shock in Indian scenario, sepsis is most common etiology. Therefore, we tend to start antibiotics early. Even when we see the babies in shock, we start with the antibiotics. If it comes to be other etiology, then anyway you can stop the antibiotics. Whenever the babies are well and they crash on second or third day of life, sudden collapse, always have a high suspicion of duct dependent lesions and have a low threshold to start with the prostaglandin, even though if you have not done echo also. Whenever you are palpating pulses and doing non-visible blood pressure, always make a habit to do it all in all the four limbs, especially in upper limb and lower limb. Pre-ductal saturation in the right hand and post-ductal SpO2 monitoring saturations, you can put the probe in any of the two lower limbs. Blood pressure is not the sole component to define shock, and it is not the sole thing to monitor while managing the shock. It has to be collaborated with the other clinical parameters. Echo is always useful. So whenever the inotropes are not acting as per your expectation, always tend to rule out the issues by doing the echo. Clinical indicators are very good to assess early, and then once you pick up the shock early, you manage the shock well, then the mortality rate will decrease. In preterms, always give, especially in LBWs, give normal saline bolus over 10 to 15 minutes, except in patients where you have a clear cut indication of hypovolemic shock. Choose inotrope as per the indication. Like you cannot start dopamine in babies who are myocardial dysfunction, present with myocardial dysfunction because secondary to hypoxia. Okay, you should be pinpoint as per the etiology. And in preterm, especially ELBWs, you can start with the steroids quite early. Thank you very much.